Excellent.
Okay.
Thanks.
Good morning, everyone. Welcome to all. This is going to be our first of series of grand rounds, and who else to begin the proceedings with Dr. Newman. Just a few brief words about Dr. Newman. He's been our chairman, new ICU attending, new floor attending, administrator, part of a lot of subcommittees in the hospital, involved actively in research even to this day. It's been a pleasure knowing and working with Dr. Newman for 3 years, with almost like 4 decades of experience in neurology and teaching residents. He has been an inspiration and a role model for everyone, including me. We always have a tradition of kicking our hands-on series with Dr. Newman's updates on stroke. So I'm pretty sure this is going to be a wonderful talk, and I welcome you all to have it. You will enjoy the talk. Thank you.
Thank you. Thanks, sir. You just look at say it. So what I would say is, as we start this, is that we are still waiting for the next major breakthrough in stroke. So there are not going to be any major new concepts. The breakthrough that I think all of us are waiting for is a form of nerve protection, and we don't have it. And that's where it is right now. There was only one major trial that was conducted this year on nerve protection, and that would fail, like all other fails have done. All the trials. We continue to see animal models and mechanisms that seem to work in model systems that simply don't work in human. We don't know if the problem is the way that we're testing them, or that there's something unique about translating it into the human. At any rate, what is happening right now, there's a huge amount of enthusiasm, and you can see that here in our own medical center as well as all over. There are a lot of things happening. There are a lot of very practical questions that are being answered regularly now. The things that we weren't sure about, how to treat, when to treat, that sort of thing. And we're seeing a lot of information coming out in those regards, including the sorts of things that we're working on, both program development and even some research now. So this talk is going to be very much a very practical talk, and that's the way I would set your head around it. The format that I've chosen, because there are no major new concepts, and because it's just a lot of information, is in general, I'm simply going to state the finding of the papers that I think have been most important, right? Anything that I put up here, this will be our outline, anything that I put up comes from a paper which, in my opinion, would stand pretty reasonable scrutiny when you look at the strength of the information. And if it's less than that, but it still is worth talking about, I try to indicate that. Also, I think that we'll have time for questions, and so rather than holding your questions for the end when everybody's trying to remember what you're talking about, raise your hand or throw something soft, and we'll deal with it right then, okay? The talk I've chosen to break up into prevention, intracranial hemorrhage, some information from the basic sciences, then getting into treatment, and then we're going to do this sort of modern medicine sort of thing. So again, lots of information. So let's start with prevention. So here, this is a good example. This is 6 papers that I'm summarizing here for you, okay? These are the factors that are or are not, have or have not been associated with ischemic stroke. Some of them are a bit interesting here. So look at the secondhand stroke, secondhand smoke, doubles the risk of either stroke or death. Okay? A lot of things, by the way, that are going to be presented are things that we all knew, but never had data for. And now we're looking at data, all right? Sepsis increases the stroke risk as 28-fold. So again, I think we have the sense that people with sepsis are certainly at risk for stroke. 28-fold for ischemic and 13-fold for ICH in the first 2 weeks, and then stay 4-fold elevated over the course of a year. So that joins other conditions such as, for instance, liver transplant and renal transplant. Liver transplant has a 70% likelihood of a stroke in the next year. Renal transplant, 50%. All right? Another thing, again, that we know for a long time is that a high CRP increases the stroke risk of internal carotid disease. The CRP is an endothelial marker, and that's the way we use it. It's the best marker that we have readily available for activation of the endothelium, all right? Typically an endothelial inflammation. And that's an important factor. I only put it on there, that's not at all new. I just put it on there because I want to reemphasize this point, that the CRP increases whether you're talking AFib, diabetes, ICA disease. When you have those risk factors combined with an elevated CRP, the risk of stroke goes up astronomically. That's an important marker. Factors which are not associated with ischemic stroke include cannabis, aortic valve calcification, and testosterone therapy. And by putting them up here, I'm telling you that there are good papers that looked at these as risk factors, and they were excluded. So this is the sort of thing we're going to be doing here. All right, let's focus on, yep.
One question for the ischemic. I just want to know a little bit of the lipid profile. Now, used to be, we very aggressively treated, low density. At this stage, a lot of news come out to say, lipids are not that critical.
Yeah.
What's the current, the guideline for?
Well, I think so lipids are more important as a risk factor for MI, and cigarettes are more important as a risk factor for stroke. So yesterday, I saw this 56-year-old guy, I was doing a consult in the cath lab, peripheral vascular disease since his early 40s, smoking 2 packs a day. But the primary doctor doesn't say a word to him, okay? Then he has an MI, he's still smoking, okay? But, it's like now he's having carotid artery disease, he stops smoking, okay? And that's probably correct, actually, because the cigarettes are a huge risk factor for stroke, and the lipid profile is more of a risk factor for MI, okay? Having said that, however, and go back to the CRP, if you have an abnormal lipid profile and an elevated CRP, you certainly should be on a statin, because one of the influences of the statin, this has been known for, a decade or more, is that the statins reduce CRP. So they are important. For instance, right here on this slide, if you want to reduce the complications of endarterectomy, you need to have the person on a high-dose statin. See? So
high means 80 milligrams.
80 milligrams of atorvastatin, maybe 40 milligrams of Crestor. Those are the 2 drugs right now that are being used.
Also, I'm surprised that you mentioned that the marijuana not increase the risk.
Not a risk factor.
We saw all the patient here. You saw
No, I think.
RCVS.
I'm just surprised.
I don't think so. I think 70% of our population is smoking grass. I mean, if you look at the. Yeah, I mean, go find.
They also have other risk factors for sure, but they come here and they're all positive.
Go find a drug screen with a negative marijuana around here. It's not going to happen.
I'm surprised.
Yeah.
I don't know.
Actually, marijuana has been studied. Marijuana was studied by the, the Institute of Medicine around 1982. And was found to have no associated health. The only thing they said was, this is after Bob Moore, who was my chairman at the time, was on that committee. That's why I knew. And they said that the only thing that they could find about marijuana was after you smoke, it impairs motor coordination. That's a definite.
It does not increase the risk for the small vessel disease.
It does not. It increases the risk for a car accident if you get in the car, though, for sure. That was their only conclusion, literally. And if you smoke, the other thing that they did say, that a joint, had about 4-fold times the carcinogenic potential of a cigarette. So if you were smoking 5 joints a day, it's like the equivalent of a pack a day. I don't know too many people who are smoking 5 joints a day. Or they need to get better stuff, is what I guess I'm saying. So, all right. On the ICA disease, the MRI, so we have always known Hopkins had a protocol for looking at the carotid plaque. It took about 2 hours, and you had to anesthetize the patient in order to do it. What makes this new is that this is about a 5-minute MRI protocol on a 3 Tesla magnet. So this is practical. This is not bad. And if you use it, so if you're looking at the plaque, you're looking at a 70-75% stenosis. You can't make up your mind if this guy should go to an endarterectomy or a stent or however you want to treat it. Using the MRI will help because it can identify the presence of a plaque hemorrhage. And once you see a plaque hemorrhage, you know that this is a high-risk plaque. So there's that. A meta-analysis, this is under the categories of just confirming what we already know. When you compare, there's a meta-analysis of about 8 studies related to endarterectomy versus stenting. It continues to be the case that this confirms that there's an increased risk of stroke of stent compared to endarterectomy. That is definitely true. And surprisingly, CEA actually has fewer periprocedural complications than stenting does. And even when I go back to Wisconsin, when you had a patient who was, where you wanted to do an endarterectomy, but they had a lot of medical comorbidities and would be at high risk. So what we did was we did the endarterectomy under local anesthesia. If you don't want to do general anesthesia, if you think that's what's going to pose a risk to the patient, then don't do it, okay? Simply do the endarterectomy under local. And we did, I don't know, maybe a quarter of all of our endarterectomy. We did 180 a year. So maybe 40 to 50 of them were done under local. We don't do things under local here at Einstein. Our anesthesiologist, it requires a deep nerve block in the neck, and that's a skill that our anesthesiologists do not have. The other things that this is emerging, that is during the procedure, you see this now in neurosurgery as well as in extracranial vascular, that you should be doing intra-op ultrasound or angio to confirm that you put the stent where you want, that it's clean, that there are no shelves, that there are no other problems that are there, so that you can correct them before you leave the OR. All right? And of course, using antiplatelet at the end of the procedure is important, and using a patchplasty rather than using a Gore-Tex or other graft rather than vein. And then we already talked about the high-dose statin, probably related to CRP.
Joe, you mentioned is who is a good candidate for the CEA versus stent? Which one you make a decision? Because it's always confusing, what kind of, based on what kind of pathology, are you on the imaging study?
So the way that we thought about it, beginning at Wisconsin, which has carried me through and hasn't needed modification, is to, this will sound weird, ignore the patient. Okay? It's not the patient that determines which procedure. It doesn't matter what comorbidities they have or don't have. It's irrelevant. Either one, you can do the endarterectomy or the stent. What determines which is best, for the most part, is the nature of the lesion.
Yeah.
Okay, so take a couple of examples. If you had a concentric calcific plaque, a deeply calcific plaque, you're not going to be successful with a stent. You need to do an endarterectomy. If you had a ball valve, we had a patient a few years ago who had a ball valve thrombus going up into his ICA, you wouldn't want to put a stent in there, okay? You do an endarterectomy. On the other hand, it'll take dissection. You wouldn't operate on a dissection, okay? You'd stent it. Or a stenosis which is related to radiation therapy, that definitely you want to stent because you don't want to go surgically into that bed. Those would be the main things. Very often, I would say half the time, either procedure will work perfectly well. So here's another thing. If the bifurcation is up above the mandible, and you'd have to crack the mandible to do surgery if they can't reach it without, so you do a stent. If the lesion, some people have their bifurcation actually in their chest, you'd have to do a thoracotomy. You wouldn't do that. You'd just put a stent in place. So those are the sorts of things that determine it. As I say, all other things being equal, you could do either procedure. Then I would say, and this is a surprise, but from the CREST trial and confirmed, the older the patient, the more likely you should do an endarterectomy, not stent. You don't want to be stenting the older people because they have more tortuous vasculature and the complication rate goes up. They also have more complex plaques.
So to continue that question, you just mentioned, is the CEA good? The CT angiogram is good enough, or a lot of times, in order to do bad picture, you need to do the angiogram? Sometimes
absolutely, both. I would say the CT angiogram is amazingly accurate, and the large 90% of the time or more, when we do an angiogram, because we're uncertain about the CTA, the findings on the CTA are confirmed by the angiogram. And the CTA is really very, very good. Every once in a while, especially for collaterals, Sri has a case over at Montgomery this week that he's been dealing with, and we needed to know what the collaterals were. And There are non-invasive imaging techniques, again, the sort of thing we do in Wisconsin where with the MRI, that you can get that collateral flow, but in most places you cannot do that. And so the easiest way is just to do an angiogram, see where the cross fillings, where the filling's coming from. So we still do occasional angiograms, but then we do those typically thinking that if we find so-and-so, we're going to proceed to stent. But if we find such and such, then we're going to stop and do an angiogram. So it's like almost like a staged procedure. I'm going to put in, since there are not a lot of pictures related to today's talk, not a lot of graphs or other images, I chose just to put in my own images. All right. So this is Philadelphia. Okay, anticoagulation. So you have all these trials, the Rocket trial, remember, and the Aristotle trial that suggested that NOACs are better than warfarin. And in a real-world study that was done, just one medical center, everybody in, the results of those studies were confirmed. That's all. That's the point, is that in the real world, they really do work. Warfarin is here. We always question of, should you give warfarin to 90-year-olds and that sort of thing? So the answers that are coming back, and you're going to see this a couple times, the answer is yes. You're better off giving them warfarin because overall you'll have less mortality, you'll have fewer strokes, you'll have fewer major complications, but there's a cost. And the older people are not going to do as well as the younger people. They are higher risk for virtually everything that you do. So when you give them warfarin, there's still benefit overall. The risk benefit is positive, but you're going to see more hemorrhages in the elderly, and that's that. When you get to anticoagulation, here's a common theme that you're going to see, and that is the influence. This year you saw a lot of data on the influence of chronic kidney disease on the management of stroke. And this is just the first example. And in anticoagulation in atrial fibrillation patients with chronic kidney disease, you have 3 studies that are in here, that basically it is useless if the patient has a GFR of less than 15 or is on hemodialysis, but you increase the risk of intracerebral hemorrhage. So this is, I wouldn't do this anymore. Okay, anticoagulation for AFib in patients on hemodialysis is the risk benefit is not there, okay? And so I think that's a practice probably we need to discontinue, move to antiplatelet, and never mind what the CHAD score is. Here's another one. This is going to be emerging over the course of this talk. An embolic stroke, so clinically defined embolic, it's not athero, it's in a leptomeningeal vessel. So embolic stroke of unknown origin carries a 4% a year risk. Now you should, if you take 1,000 patients who've had a stroke and look at their annual risk of stroke recurrence, it will be about 1.9%, so let's say 2%, all right? That's all comers, all right? Everybody, lacunar stroke, whatever you want, coagulopathy, throw them all in, it's going to be about 2%, all right? And if they define this embolic stroke of unknown origin, they find an increase to about 4%. We're going to be dealing with this several times. We'll come back to it. This was nice. A cardiac MRI identifies, and related to this in a way, is that cardiac MRI identifies LV thrombus in 20% of patients with cardioembolus. And the TEE only found 1 out of those. Literally, they found 10 of them, and the TEE had identified only a single one. So the value of the TEE, which has never been my favorite test in acute stroke, is diminishing. It's really not that wonderful a test. And I think we can expect that a cardiac-gated MRI is going to replace it in the near future. The patients who were entered into this study all had had stroke and either had an MI or an EF less than 50%. So when you look at this 20, you say 20% of LV thrombus, like what was the patient population? The answer is, well, stroke and MI or stroke and heart failure, okay? But it is still the case that if you had studied these people with conventional techniques, you would not have seen the LV thrombus, and only the cardiac MRI showed it to you.
So just
Yeah, Annie? One second, Cameron. Go ahead, Annie.
Oh, okay. My question is for the second point, warfarin in more than 90 years
Yeah.
old. In terms of the ICH risk, did they segregate a patient with the presence of amyloidoangiopathy or not?
No, these are no, I would say people would not do it in amyloid.
Oh.
That would be a separate subset.
So for the last sentence, for the MRI versus transesophageal. This condition, the transthoracic echo has no help at all.
Well, we love the 2D echo, so we use a 2D echo all the time. I mean, every single stroke patient who comes in, unless they've had one in the last few months, is going to get a 2D echo. And I think that's a great test because it's completely non-invasive and gives you enormous. We did a study, Terry Madelon's son and I, Josh, did a study, I don't know, 10 years ago here, in which we looked at the value of 2D echo. 45% of them are abnormal, 20%, over 20% gave us information that we did not have until we did the echo. And that was a consecutive series of 100 patients, no selection at all. So it's a very valuable test. But the TEE poses some risk because they have autonomic instability and most of the time you don't need it. And it turns out it's also not the most accurate for giving you what you want. This, I don't know what to call it, the CHADS-2 vascular score. So it's a pretty good score, and I've put it up here for you. This is where this comes from, this paper. And by the way, you have the references. I sent them around as an email, so you actually have the outline of this talk and the references with it. So anything that you want you should have the reference. Most of it comes from Stroke. There's a smattering from the New England Journal, Neurology, and a couple of other places. I'm not sure I like this, so I'm putting it up for sort of discussion and just sort of putting it out there. So the threshold for starting warfarin, they said, is a stroke risk of 1.7% per year. I don't get that, okay? Because all people have a risk of 1.9%. So this isn't right. There's something wrong here, okay? And I don't know what it is. They're saying that risk benefit for starting a NOAC, these are all patients in AFib, everybody's in AFib, but starting a novel and oral is less than 1%. Everybody who's ever had a stroke has a risk of almost 2%. So I don't know what they're saying. And I read the paper and I'm going, what? I put these things up here. They're saying that a CHAD score of 0 has a risk correlation to a risk of 0.68% per year. I don't even know who that is. That if they have a CHAD score of 1, it's 1.61, you can read it. But then there's also these wide confidence limits. And you can see that anybody, so if you're 65, you're going to have a 1. If you're female, you're going to have a 1. So if you have a female in AFib, that means you ought to be on a NOAC, period. I don't know that I agree with that. Okay, I don't know, the data doesn't really make sense to me. I don't know what they're saying. So that's sort of where I am with that. All right, let's go over to antiplatelet therapy. Still talking about prevention, of course. If stroke occurs, and here's a question that we've had, we get asked this all the time. If stroke occurs on an antiplatelet, should you change the dose, should you switch, should you add? The answer is either switch or add. Okay, so look at this. This is a significant hazard ratio is reduced by 1/3. So you reduce by 1/3 the likelihood of recurrence if you either switch antiplatelet or add an antiplatelet. So I think that needs to be incorporated into our practice. The CHANCE trial, you may remember the CHANCE trial was a Chinese trial in which they gave dual antiplatelet for 3 months and showed a significant reduction of stroke recurrence. That was repeated in a Korean population, and they did not find the same result.
Yeah, what about the prolonged use of the dual therapy, especially in patients that have
We have no new data on that.
Or increased risk of intracranial hemorrhage and GI?
You definitely increase the risk of intracranial hemorrhage. There are certain conditions where it appears to be useful, but I would say that probably would be next year's grand rounds because there's no new data on that. Yeah. And this is a data-driven talk. This is only published materials, and with one exception that I'm going to talk about an unpublished study. The antiplatelet resistance, which we've always, very early on, we introduced the Verify Now because we thought the platelet resistance was important for us to know. This year, there's just a whole host of trials on antiplatelet resistance. So after stenting, resistance causes higher thrombosis. Right now, for instance, if you wanted to do a pipeline stent for an aneurysm, you would test the person for P2Y12 resistance before you would put the pipeline in. because if the Plavix isn't going to work, then you better not put the pipeline in until you get them on something else. Now you have other options. You can use Brilinta, would be an excellent choice. You could use the old drug ticlopidine if you want. Ticlid would be, again, an excellent choice. So, but you have to be careful. If this is, as I said here, if the Plavix doesn't work, then it doesn't work, okay? In other words, if it doesn't alter the P2Y12 assay, then the patient's going to be at risk for stroke recurrence as if they're not on anything. So going back to, if it doesn't work, switch, add, switch, change. Don't do the Einstein. The height of insanity is doing the same thing over again and expecting a different result. Okay? Don't do that. Here's another, and we've sort of known this. The other thing that makes antiplatelet resistance is an elevated, uncontrolled diabetes and kidney disease.
Abnormal hemoglobin A1C or uncontrolled diabetes?
This was elevated hemoglobin A1C.
Like hemoglobin A1C abnormal
Say 9,
6.5.
9, 9.
Okay, got it.
Yeah.
So uncontrolled diabetes.
Dual antiplatelet is not beneficial in chronic kidney disease, but the risk goes up. So both an anticoagulation and dual antiplatelet should not be used in hemodialysis and people with GFRs around 15. All right? You want to do it. They're at risk, okay? You're not helping, okay? You're just increasing their risk of hemorrhage. So don't do it. You need to resist that impulse. This was a nice study. This was not, this is sort of stroke related, but I think it's an important result anyway. And that is 2 baby aspirin a day reduces preeclampsia in the high-risk pregnancies. And that's a big reduction. You're getting rid of 2/3 of the preeclampsia by 2 baby aspirin a day in people who are at risk. Yeah?
The first thing about the stroke recurrence on antiplatelet, so that part of adding would be for a year, it would be indefinitely.
Indefinite. I think the answer is indefinite. Yeah.
Follow-up question.
Yep.
What about the risk of hemorrhage in that case?
The more there are no. I've looked at this for a long time. Anytime that you reduce the risk of stroke through an antithrombotic agent, you will increase the risk of hemorrhage. There are no antithrombotics which can improve stroke risk reduction and not increase the risk of hemorrhage. There's no such agent. Even if you did something like, we used to use Dextran around carotid endarterectomy in high-risk cases as an anticoagulant, you still increase the risk of hemorrhage. There's no, now, there are relative risks, and we're going to talk about that in a minute or two, I think. But, for instance, NOACs are better than morphine, okay? So you can get more, some drugs have more efficacy for the risk of hemorrhage, okay? And then we're migrating to those drugs. But there's no drug that's free. And the more intense you make it, that's always true. The more intense you anticoagulate the person, the higher the risk of hemorrhage is going to be. So dual antiplatelet must carry a higher risk. This is inevitable.
Sure, yeah.
Using our current agents, I would say.
Is it better to switch first?
Pardon?
Is it better to switch first, and then if that doesn't work, do duo?
I think we don't know the answer to that right now. They didn't have that level
I
of
do.
discreteness in the study. I would say, so let's say that you have someone on Plavix. So we do this, right? You put someone on Plavix, they have a TIA, you check it, it's not working, okay? So I had to switch them to aspirin. And I don't see the point to adding aspirin to the Plavix if the Plavix is not working, okay? And if for some reason I wanted a P2Y12, a new step or something like that, then there are a lot of good drugs. Brilinta is a wonderful drug. And we don't use it. Why don't we use it all the time? Because they have to take it every day. If they miss a dose, they're not anticoagulated anymore. That's not good, okay? So especially in our population, I always say, when I'm talking to family doctors, you say, does anybody here ever have a patient who's missed a dose of medicine? So, yeah, come on. That's just human nature. So that makes the drug dangerous, but if you need 3 months of this and you wag your finger and you say, this thing's going to occlude if we miss a dose of it, you probably get 3 months out of it.
One more question.
Sure.
So follow up on that first point.
Okay.
If stroke recurred on NOAC, are there any data on what we do?
No, they do recur. And I which is no.
Switched to
Yeah, and while there's no new data, I have, on the review of the trial, the apixaban, or Eliquis, appears to be the drug with the best risk-benefit profile, but that's a soft call, because you really cannot compare the different trials. The Rocket trial, which was rivaroxaban, clearly had sicker patients than the other two trials at the time, and it's not a good idea to compare them. And yet, in all this metadata, the apixaban looks very good. I would say that. The apixaban looks very good. I wouldn't say that you know, the other, this is my home in Wisconsin. It was my home in Wisconsin. That's every morning it was like this. It was amazing. Yeah. And that was just what you woke up to. We had no curtains on the windows. You just let that come in. I mean, it was, okay. PFO closure. So this, talk about hot off the press, this is this week's New England Journal, all right? 3 papers, 3 primary research papers on PFO closure and 2 editorials, okay? I've given you the reference because I didn't have time to put it in the one that you are working with. Let me begin by, I've actually written a letter to the New England Journal on this in the past. This field is a mess, and you're gonna see it in these 3 articles. You'll see good and you'll see bad, all right? So prior studies have strongly suggested, from data from a researcher named Mas, so prior studies have strongly suggested PFO alone does not increase the risk of stroke. So how many, if we're 50 of us in this room right now, 10 of us have a PFO. Okay, we're not at risk for stroke because we don't have an atrial septal aneurysm or a possibly, I would say, a large interatrial shunt. But here, look at this. So the PFO, right, is a failure of adherence of the 2 leaflets, right? So it's like a baffle, okay? It's like this. So they overlap one another. It's not a secundum defect, okay? They overlap one another. So you see, you can't see me now. But now give me an atrial septal aneurysm, and you can see me. Now you see me, now you don't. And so as the PFO actually opens with the atrial septal aneurysm, and that's why I think that it presents such a high stroke risk. And the large intraatrial shunt is not as well documented. We'll get into a little detail. So the data of Mas et al. From 2001 is, as far as I'm concerned, the only useful data on PFO up until this week, all right? And what he showed was that if you put people, he took 800 patients, 200 with no PFO or ASA, 200 with a PFO, 200 with an ASA, and 200 with both. And he put everybody on 325 of aspirin and followed them for 5 years and looked at stroke recurrence. Everybody had a 1.8% chance of recurrence, whether you didn't have any or you had one or you had the other. But if you had both, you had an 8% per year risk of recurrence on aspirin. Could it be clearer? So if you have both, it's both that is the risk factor, and if you have both, you cannot rely on antiplatelet. Now that is about as clear as it could be. So I don't know why anybody didn't make use of this, but many trials did not, as you're going to see. And over the years, I would say that there's fair data that a large intraatrial shunt also increases the risk of stroke in PFO, but in the 4% range. This is 8% per year. This is maybe 4%. Prior studies and current studies fail to take this into account, with one exception. So, Mas is back, okay? Mas is probably the senior stroke investigator of France, okay? Able to bring together large multi-center trials. 663 patients with a PFO and either the atrial septal aneurysm or a large intraatrial shunt. If you don't have both, you don't get into the study, period, okay? Nobody with a PFO alone is in this study, okay? Then he randomizes them 1:1:1 to PFO closure, anticoagulation, or a single antiplatelet agent. His trials are so clean, it's amazing, okay? He follows them for 5.5 years and looks at the risk of stroke recurrence and major bleeding. It's like, what could be clearer, okay? In the closure group, there were no strokes, okay? I think that's a freak. I wouldn't say that, you know, but that was the result. There were no strokes out of the 238 patients who had closure with a less than 1% bleeding complication, not surprisingly, because they're not on an anticoagulant. Now, they need 3 months of dual antiplatelet after the closure, okay? So closure you always do, in all the trials, you have to do 3 months of dual antiplatelet. Then you can stop, you don't need anything. If you went to antiplatelet, so you had a 14 out of 235 stroke recurrence rate with a 2.2% bleeding rate. So what's that? That's about a 7% risk. And here with anticoagulation, very effective. 3 out of 187 had stroke with a 5.3% bleeding rate, pertinent to Aparna's question. Of the people who were anticoagulated, 93% used warfarin. I mean, this study began 10 years ago. Right? Okay, so there you go. All right, I don't think you need to interpret it. That's the results. Less bleeding, less strokes when you do closure. Now at Wisconsin, we closed, I don't know how many, but between 400 and 800 PFOs, which had atrial septal aneurysms and or large interatrial shunts. We were doing all of the closure for a population of maybe, I don't know, 12 to 14 million people. So we did a lot, and we were the only center doing them. And so we got to follow a lot of these, and this is totally consistent with what we were finding. There are procedural complications that I was not aware of, and that is that 4.6% of people who have closure develop atrial fibrillation versus 0.9% of the group that got antiplatelet. So, you know, the question is, what does that mean? And we'll come back to that. All right. Now here's a second study, Jeff Saver. This is an American study. 980 patients with a PFO and cryptogenic stroke. So they don't have necessarily an atrial septal aneurysm, and they don't have an interatrial shunt. Okay? They have a cryptogenic stroke and a PFO. Now, that's going to be a heterogeneous population, right? That's just not the group that you want to study. At any rate, they randomized them to closure or medical therapy, and medical therapy can be either anticoagulation or antiplatelet. This is the standard stroke. This is what I wrote the letter about. It's like, what kind of stupidity is this to not target your high-risk group so you have a heterogeneous population going in and a heterogeneous management? It's like, what kind of study are you thinking about here? You're not going to get any useful data. So they followed them for 6 years. They had stroke recurrence. There were less, so when you close them, you had a lower hazard ratio, only half the number of strokes. This is the data, but the answer is half the number of strokes. And these people had thromboembolism if you close them. Why would they do that? Because they had coagulopathies when they went into the study. It's like, what kind of nonsense is this? I don't get it. I don't. And Jeff is really good. I have no idea why he would design a study like that. Here's another European study from Sundergaard et al. 664 patients and a cryptogenic stroke, the same thing. Randomized, at least this time, here at least you don't have a confounding influence of warfarin. They randomized them 2-to-1 to closure versus antiplatelet. They followed them for 3 years on average. You have a significant reduction in stroke recurrence. Whether you do it by clinical or whether you do it by imaging, you have a marked reduction in stroke. So my conclusions from when you put these 3 studies together is, first of all, that a heterogeneous enrollment and treatment is going to create mud. All right, and the studies, as far as I'm concerned, those 2 studies should be ignored. PFO closure is superior to anticoagulation when the patients are properly chosen, and antiplatelets don't work at all when you focus on the population who is at risk, which are those with the PFO and the interatrial aneurysm or large shunt. Large shunt, by the way, was defined as 30 microbubbles crossing within 3 cardiac cycles. They actually defined it very clearly. You have a 3.7% absolute increase in atrial fibrillation. But if you take this population, okay, who has a PFO and the large shunt or the aneurysm, antiplatelet doesn't work. Okay? So if you don't close them, you're going to have to anticoagulate them. So you will have to anticoagulate 3.7% of the patients who get closure, but you're going to have to anticoagulate 100% of the patients who don't. And that's sort of where I am with this. You cannot, the take-home message is that the PFO alone is not the risk factor, that you have to have one of these other concomitant factors. And when you have that, antiplatelet doesn't work. You either need to close them or you need to anticoagulate them, period. Okay? This is from the Keweenaw. This is this time of year in Keweenaw. Keweenaw is in the Upper Peninsula of Michigan. This is the most northern spot in the United States, and it is gloriously beautiful. It is, rivals Vermont in its foliage. It's a gorgeous place. 1 week later, everybody here was snowed in. That's it. They don't get out for the year. Intracranial hemorrhages, let's move on. All right, we better pick up the pace also. Endoscopic evacuation of the ICH, on average removing about 70 mils within 29 hours, produced many more good outcome than leaving the hemorrhage in place. So endoscopic approach is developing as an important approach to the ICH. You know, I'm sure you're aware that open craniotomy has not really had a major improvement in the outcome. But when you do this endoscopically, and this is just the most recent of several studies that suggest that an endoscopic evacuation is a good thing to do. We always use the ABC over 2 rule. If the hemorrhage is irregular, you overestimate the volume by a little bit. Frontal ICHs have the worst outcome. I don't know that I would have predicted that. And edema, this is a no-brainer. Edema worsens outcome. There was a nice Pontine hemorrhage prediction scale. We see some Pontine hemorrhages, and this was a very nice scale that was based simply on the GCS and the volume of the hemorrhage. So we've always excluded the Pontine hemorrhage from the usual rules that we use for the cerebral hemorrhages. This is a very nice scale, and you can just see the groups, and it goes from people with less than 5 mils and a GCS of 8 to 15 have only a few % chance of a major disability. They're likely to do well. At the other extreme, greater than 10 mils, presenting with a GCS of 3 to 4, they're probably not going to survive. So it's a nice scale. You have the reference. It has a very good predictive value, and I suggest that you take a look at it. This is a really good paper. This is something that we have observed repeatedly. Our radiologists talk about it all the time. We always see it. This is really easy. And the question is, how do you predict the expansion of an intracerebral hemorrhage? And remember, there's the dot sign. There's the, all these different things you need to forget about. Okay? This is really easy. You take the non-contrast head CT. If you see heterogeneity, and this is not projecting nicely, but take a look at the original pictures. If you see heterogeneity, dark areas and planation, filling defects within the hemorrhage, and we see these, if you just think about it, you see them all the time. If you see them, they are the ones who are at risk for the expansion. They have all these cute names. I put them up for fun. Black holes, swirl signs. These are all different papers. The blend sign, and a paper on the blend sign. It doesn't matter. What they really all talk about are heterogeneous hemorrhages, where you see areas that are not hemorrhage and that they're probably clot, presumably. The thing has already been clotting, rehemorrhaging, and so, yeah, you're looking at it directly. The thing, it keeps rehemorrhaging, and so, not surprisingly, it continues to rehemorrhage.
I just want to mention this, because you saw this black, this area, indeed, this is fresh blood, it's not clotted. So that's predicted.
These?
Yes.
Yes.
Are you
This
saying
is
not
called
clotted?
active bleeding.
Yes, this is active.
You are looking at active
Because
bleeding.
they're not show up yet. That's the theory of the source sign. That's all the, particularly this is very.
Why are you saying that? Why would it not be?
See, because what you saw on this, the bright sign on the CT scan, this is clotted blood. That's why it's the white sign. If it's not clotted, it's fresh bleeding.
Okay.
Particularly in the, the epidural. That's the reason. That's
Okay.
why they say you have fresh blood.
Reverse that.
Yeah.
Okay. Thank you. Okay, major question. Lots of data. I think we can almost get to the point of being comfortable with a recommendation after the data this year. So the question is, should you anticoagulate after an intracerebral hemorrhage? And by and large, the answer is yes, you should. You should, okay? So, you know, we're all creatures of what's our last case, what happened to our last patient. Of course, that's not the way to make decisions. So it's really nice when you get some good data, and good data we have this year. This is a paper that looked at 6 different studies. And in these studies, they, on average, restarted anticoagulation 11 days, 10 days, 39 days, a little under 2 months, 31 days, or less than 6 months, okay? And they reduced the ischemic events by 34%, which is a big number. So 1/3 less ischemic events. And there was very little increase in bleeding in these major studies. And no correlation at all with the risk of bleeding depending on when they started the anticoagulation.
Wouldn't it be related to the size of the bleed, like small bleed versus?
Yes, so I'm going to come to that. The answer, absolutely, yes. Simon's saying, well, is everybody the same? That's another way of phrasing, you know, all people the same, and the answer is no, all people are not the same.
So along those lines, also the cause of bleeding.
Yes, so no question, I'm going to modify. So here's another, this is separate study. Starting anticoagulation after an ICH appeared best to them at the 7th to 8th week. The death of stroke is 15% if you restart anticoagulation versus 25% if you don't restart anticoagulation. So this is everything that you care about, right? That's all of it, including hemorrhages. So there's significant benefit, an absolute risk reduction of 10% by restarting anticoagulation in this study 7 to 8 weeks later. Another study, dabigatran versus warfarin versus not restarting. So 3 arms to the study. The highest risk of all is not doing anything. Not restarting anticoagulation is the worst outcome. Dabigatran is better than warfarin. Therefore, it doesn't take a lot of imagination to say where I'm going with the recommendations. So you should anticoagulate these people. I'm going to choose 8 weeks as my sort of standard start. But of course, like both Anishi and Saman are saying, well, everybody's different. And so you always modify, I always modify what I'm doing to the patient according to their risk. And I look at it 2 different ways. This was true with dual antiplatelet too, okay? What's the risk of an ischemic recurrence? And what's the risk of a hemorrhage? Okay, so take a simple example. Annie was asking, what if the person has amyloid angiopathy? Well, then the risk is too high, and I'm not going to do it, period. I mean, that's an extreme, but I'm not going to do it, right? But most people, you know, what's their echo look like? You know, do they have an LV thrombus sitting there? I mean, you get pretty, do they have an EF of 10%, you know? So what's the risk of the recurrence? What are their risk factors, that sort of thing, and that's going to move me earlier, right? Versus how big is the hemorrhage? What was the cause of the hemorrhage? Is it something, was there a risk that I could eliminate? Was it associated with a head trauma? Is the person going to be in the nursing home from now on, that they're going to be at lower risk for falls, that sort of thing? Are they going to give up? Whatever it is, okay? Were they taking red clover as an over-the-counter supplement? I mean, you know, stuff like that. So and then here, a paper, you know, made. So prothrombin concentrate, you should not use fresh frozen plasma to reverse a INR. Okay, that's crazy to do that.
Judge, do we have any, how to reverse all this new oral anticoagulation?
Reverse the NOAC? Well, the dabigatran has its own unique drug, and there was a paper that I didn't even put up. It works. So there's this unique antibody against the dabigatran.
Usually the half-life is, you know, the 12 or 24 hours. If
right.
you don't do anything within this time window, after next day,
that is true.
too late to do anything.
A lot of people are still using, there is some evidence that high-dose prothrombin concentrate is it's not effective, but it improves the situation compared to doing nothing. So that's what I would say. But with warfarin, it's just crazy. I mean, you know, it's been 24 years since I've used fresh frozen plasma to reverse INR. I mean, it's just, I don't know, I don't get it. All right, we're still on the topic of hemorrhage, on subarachnoid hemorrhage. Very little data in this literature. Not a lot of, I would say the only maybe new information on subarachnoid hemorrhage is the notion, so everybody's always worked with the 7-millimeter aneurysm as the aneurysm which, even if asymptomatic, should be operated upon. people are moving toward posterior circulation aneurysms, probably rupture sooner at a smaller size. So maybe by 5 millimeters in the posterior circulation, you really worry about these things. The data in stroke literature, the only thing that I saw is that I thought this was interesting. Almost 20% of all patients with subarachnoid hemorrhage who survive end up with a shunt. So it's a fairly large number. We deal with this all the time in the ICU. And just as a guideline, roughly 20% are going to have a shunt. Surgical research. So there's we're going to get into some research trials are evolving. Okay, the idea of the randomized clinical trial. This is, you know, one other thing that just has always bothered me. This is not the way to do research, in my opinion. The standard randomized clinical trial is cumbersome. It takes too long. It costs too much money, and by the time the trial finishes, the techniques that were used in the trial are passé, okay? So you need a design for research which deals with that. One approach, not the only approach, I'm going to show you a nice approach that's coming, but an important approach, especially for surgery, where you really have a hard time doing randomized trials, and blinding in particular is almost impossible. Is registries. A paper suggested, this is always a question that we get asked very frequently. Can a woman who is pregnant and had a headache, found to have an AVM, can she deliver vaginally, or does she need to be delivered by C-section? This goes back and forth. This year the answer is she probably needs a C-section, because these things in this study, they do rupture during pregnancy. Last year the answer was let them deliver. Hey, Barry. Oh my God, it's 10 after 9. We haven't even started. A review of dural AV fistulas is available to you. This is from Canyonlands in Utah. And it was all pictures all about the berries on the tray. You can see them up here, very pretty berries. Okay, basics from animal models. Free radicals matter. Hyperglycemia matters. Cooling is effective. All these things that we cannot apply yet in humans to stroke continue to be beneficial in animal models. I'm going to keep moving because we're late. This was in humans. So we have known for a long time that when you compare the arteries of the brain to arteries everywhere else in the body, for a vessel which has the same size lumen, the wall of the brain's blood vessel is only 2/3 as thick as the artery anywhere else in the body. That's known. That's long-standing. This paper is interesting because it compares the anterior and posterior circulation, and the posterior circulation is even thinner than the anterior circulation, which correlates with the high risk of dissections every time we try to go do an intervention in the posterior circulation. These things are thin as paper. And so I'm very, very hesitant to go into the posterior circulation with a catheter right now. All these techniques which we apply in the middle cerebral and even in the anterior cerebral or out in M2 make me very, very nervous in the posterior circulation, and we have a lot of complications. I mean, a lot, easily 10%. And that's not just here. Every place I've ever been, I dread going into the posterior circulation, and that's the reason why. Yeah, this is explaining why these vessels are just so thin. You try to put a catheter in there, they go right through the vessel. All right, this is an important question. Now, we're going to talk about the DAWN trial, but that's, we're all aware that intra-arterial thrombolysis, or mechanical thrombolysis, if you prefer, is big. We're getting great results. So given that, the question has begun to emerge, do you even need the IV TPA? And one paper said no. One paper said absolutely. If you're doing mechanical thrombolysis, whether you do or don't give IV TPA beforehand makes no difference at all. But then very recently, last month maybe, a meta-analysis of 13 studies with over 5,000 patients, this is relatively big data, suggests that you need IV TPA. If you can get it in, do it. Why? You have 27% more independent people. You have a 30% reduction in mortality. You have a 50% increase in successful recanalization. And this is an important number. Passes is the number of times they have to put the catheter up to try to extract the clot. That you have twice as many good clot retrievals if you've given IV TPA. Okay? So, yep. You know?
Bolusing first, going to IR, and letting the drip go in while you do it, or waiting 45 minutes?
So the protocol that
while
we
you-
are setting up is absolutely slick and would have us giving the IV TPA while the CT angio is being done. And everything's going to have to be parallel processing. You have this 30, 60, 90. You have 30 minutes to get IV TPA and go to needle time, 60 minutes to get the door to groin puncture, 90 minutes to be done. Okay? So those are the time frames that we're working with. And we're pretty much, you guys are achieving that right now. Our TPA times are typically 27 to 32 minutes. Our recent door to revascularization time, with one exception, have all been under 90 minutes in the last 6 or 7 cases. So, yeah, I mean, you guys are doing spectacularly well.
Does it increase the risk of a hemorrhage if you know to give
No, I
more than
don't think it does, yeah. I think,
complications, side effects?
oh, with giving IV TPA?
Yeah,
No.
before the IA.
It must, okay,
Yeah.
but we're using the IV TPA under 3 hours, so, right, you know what, I don't use just, I'm glad you clarify, in the, quote, 3 to 4.5 hour window, I don't use IV TPA. I think you're asking for hemorrhages if you do that. I wouldn't do that. Not, and especially not if you're going for mechanical thrombolysis. I think that I never have. That's
But the point
20
is,
years ago,
timing
I
window is, for the mechanical, you go to the window to 6 hours, and then you will be longer based on
our
the
window
case.
right now is 8 hours, and I'm going to show you data. We're going to look at the Dawn trial right now. Okay, before we get to the Dawn trial, so you have IV TPA. This paper suggests that you can safely give it to people on the NOACs. Okay, so they come in already anticoagulated on the NOACs, and they're saying it's still okay to use IV TPA, well, but they had a hemorrhage rate of 4%. Currently, the accepted rate is about 2.5%, so it does increase the risk of hemorrhage, but it might be worth it. It might be, to be able to go ahead and get that thrombolysis. It's a shame not to. It's a shame. If a person has a stroke on a NOAC, and a big MCA stroke, what are you going to do? Go, God damn. You know, it's like, I don't know that's the best treatment, right? But then another study demonstrated, not suggest, but demonstrated that the existing labs that we have for NOACs are useless. They are no good. So it's not even worth looking. AP, antiplatelet, neither helps nor hurts. Argatroban may actually help. But then I'm asking this question now. Given that, and this is me right here, given that we are now using mechanical thrombolysis for the big clots, okay, and we're still using IV TPA for the smaller clots, the idea of moving toward a more intense thrombolysis, drug thrombolysis, doesn't make sense to me. Because the more intense is for the bigger clots, but the bigger clots are being done mechanically. So then why would I increase the risk? If you're going to use more intense, it's going to increase the risk of hemorrhage. Why do that? I don't like that idea at all. And I think I'll predict that sometime in the next 5 years, people will look at the dose of IV TPA and say, you actually don't need the whole dose anymore. You probably can give a partial dose. In fact, what we call bridging in the 90s was 0.6 TPA and an intra-arterial thrombolysis. And I suspect that we'll end up with something like that. But I would wait on the data. We'll still use the full dose. Oh my, there's just so much to talk about. Predictors of poor outcome, and this is too good to treat. If they're older, if their NIH stroke scale is 3 or 4, if their infarct is in the posterior circulation, you're probably better off giving IV TPA, even if they're under an NIH stroke scale of 4, or even if they're improving rapidly. They look better when you give IV TPA. Indy's shaking her head. She's been an advocate of this. And remember, we don't talk about the NIH stroke scale as much as we talk about the risk of producing a disability. If stroke of unknown onset, this is very complicated. I don't want to get into this today. If you have wake-up stroke, however, it looks like about half the people who come in with wake-up stroke are really, really acute and can be given IV TPA. Now, this is an issue we've been struggling with right now, is can you give IV TPA, or is the only option IA TPA for a wake-up stroke? This suggests, now we don't know how, this is not practical yet, it doesn't guide us in the ER, okay? But it suggests that there's going to be a population, which if we can identify them, we're going to be able to go forward with our fast IV TPA. So this story is definitely evolving. And this is dawn back in Wisconsin. I wish the lights were out. This is a stunning picture. This is what we wake up to every morning. And this is to introduce the dawn trial. Wake up stroke, dawn trial, get it? Oh, it's so clever. All right, this is unpublished, okay? And this is very complicated. Barry, I'm going to go till about 9:30 if that's okay. Thank you. Thank you. Good morning, Jane. Good morning. This trial design is really interesting. So the New England Journal has run a series on new trial designs. So the idea of adaptive and enrichment. So I'll give you an example of adaptive trial design. You have 3 different stent retrievers by 3 different companies, and you don't know which one works or if any of them work better than the other. So you put all 3 in, and when you begin your randomization, you're randomizing to all 3, okay? As well as, of course, control groups, but you're randomizing to all 3 stents. You do an interim analysis, which usually isn't allowed, but now is done. You have to put more patients in. So you do an interim analysis, and you look, and you go, manufacturer C is not really working all that well. We're seeing several hemorrhages with this one. Right in the middle of the trial, you take it out. You continue your randomization in the same way to stent retriever versus control, but now you're only using 2 different stents. You do another interim analysis, and you find that this one really looks, by Bayesian analysis, really looks like it's probably going to be better than the other one. You throw the other one out, and now your trial design is only using manufacturer A versus medical management. That's what's called adaptive. The trial design is changing in the middle of the trial. It's intended to change. Enrichment is the opposite. Enrichment has to do with the patient. So you find that you start with you're doing this with your stent, and you have the control. And then you say, my gosh, look at the people over 85, okay? They're not doing well at all. You change the age limit of the trial, and suddenly you're not enrolling. Your subpopulations are changing right in the middle of the trial. And the statistics are designed to take this into account. So this is an adaptive enrichment design, okay? This is very new. This is cutting edge. There have only been about, I think, maybe 6 or 7 major studies that have been accomplished in all fields of medicine using these designs. And sometimes you don't usually even put them together. So this dawn trial is going to be assuming that it stands up when it's published, which you never know, is going to be a major step in the evolution of trial design as well as the result. Things are not clear from the abstract. So they're talking about a clinical core mismatch, which is to find, first of all the patients in have either an intracranial ICA or M1 occlusion and less than 1/3 of the MCA on CT scan, okay? So you do a CT angiogram, and this is what you find. Now they're eligible for the trial, all right? Then they have to have a core infarct of less than 50 mils on MRI or CT perfusion and an NIH stroke scale of greater than 10. And that's the clinical core mismatch. They're saying an NIH stroke scale of 10 is a big stroke, okay? And if the core is less than 50 mils, then the 50 mils cannot account for this NIH stroke scale of 10. Therefore, the patient has a penumbra, okay? And that's the way they're doing it. They're also doing perfusion scanning, by the way. The time to last known well in this study is 8 to 24 hours, nobody under 8 hours. So this is late, this is wake up. And by the way, I just put this here, no seizures. If they had a seizure, they don't get into the trial, okay? Anybody in their right mind is not going to do this with a patient who starts with a seizure. They're using the Trevo, a single stent retriever, a thrombectomy, plus medical, which is correct to state it this way, because they're doing medical versus medical alone. That is the correct way to state it. This was stopped after a safety analysis after they planned 500 patients. They only did 206. because it seemed so likely that there was going to be benefit that they stopped the trial. But the problem is that the trial didn't get randomized. So you're going to have major imbalances in who got into each arm. This is going to be a problem. I'm sure the investigators were not happy when it was stopped. I've been there. It's never fun to be told to stop early. You might think that's good news. It's not. Your study was designed for... Anyway, the outcome of functional independence, which is a ranking of 0 or 2, was reached in 48%, 50% really, of treated patients versus only 13% of controls. You could understand why the safety committee said, this trial has to stop, okay? This is not fair to randomize people into medical only, okay? This also trial was innovative in that they did a weighted ranking. So in other words, they said, well, 0 to 2, yeah, 0 to 2. But is 0 and 2, are they the same thing? No, they're not. 0 is, us, we're 0. 2 is the person has a little bit of a disability, but he's able to keep doing what he would normally do. Those are not the same. So they weighted the Rankin scale, and they said 10 points if they get a 0, and 9 points if they get a Rankin 1, which is a deficit but no disability. So they're saying, that's pretty darn good. But maybe we'll give 7 points, okay, or 8 points, okay, if they're a Rankin 2. And we're only going to give 6.5 points if they're a Rankin 3. So they weighted the Rankin scale, which is a very clever way of doing things. And that will improve the power. Remember, when you look at these neuroprotective trials, one of the explanations for why the neuroprotectants do work in animals and don't work in humans is that the outcome variable in the humans is not up to the task. So this may help find some directions that we can go. At any rate, they also found benefit all the way out to 24 hours, but they said it's best to do it sooner, time is brain, so the average was at 13 hours. The safety endpoints of mortality were less in the intervention group. In the stent retriever group, the risk of hemorrhage, someone asked that, was roughly the same in the two groups. And there's another study with the same design called Diffuse 3, which will be coming very soon. Vessel walls are damaged after intraarterial. The stent retrievers are fans that go to the vessel wall. They infiltrate the clot. They go to the vessel wall, and then you pull back. So you're denuding the endothelium off these vessels. That is happening. The Penumbra 2 device and the stent retrievers appear about the same. And we have started saying, Paul's showing us the clot. And I'm going, don't throw that clot out. Let's throw it, send it down to pathology and let's see what it is. There's a nice paper that shows emboli don't look like thrombi. Emboli are organized clots, right? They've been sitting in the heart for days. So they're organized. Thrombi that form in situ are loose, fibrin platelet aggregates. They don't look the same at all. So just do the pathology, because how often do we not know what the source of the embolus is? You got the clot sitting there. You should not waste that information. So we certainly have been doing that. We're setting up a session with Manju to go over them. I just put this in. This is the Delaware River at the bend here. This is the Ben Franklin Bridge. Philadelphia has pretty dawns too, right? Not only Wisconsin. That's from the St. James. 33rd floor of the St. James. Okay, Sampras. This may be the last study that I get through. I hate this trial, okay? This trial bore no resemblance to anything that we were doing at Wisconsin at the time. And we had already published our results. And this looked nothing like it. This trial was about stenting, symptomatic intracranial disease, stenting versus medical management. So first of all, they used the wingspan stent, which had never been used before. We did not use that at Wisconsin. They showed a 14% stroke or death in the treated group that got the stent versus 6% in the medically managed group. Now, the patients that we were entering, that we were studying, and we did a lot of these. Again, we're dealing with a population of maybe 12 million people. But the people all had failed medical management. If they could be managed medically, then we did that. We never went and did a stent in someone where we could control their symptoms by medical management. So our answer, the failed medical group, was 100%. It was like, what are they talking about, 6%, okay? That made no sense to me, and this made no sense to me, because, I don't know, we published a series of 17 consecutive for a different purpose. We didn't have any complications. I mean, we weren't having complications. So this made no sense either. So this first part is now called into question. Northwestern entered patients into a study. They weren't doing stenting. They just looked at the patients who were Sampras eligible and got the same kind of management that was used in the Sampras trial, and they had nearly a quarter of them ended up having a stroke or dying, which would be a lot closer to what I think is reality. And notice, that's worse than even the stupid wingspan stent. The only wingspan stent we've used here, that patient died. Had the stent migrated, just what they do. The stent migrates distally, okay, then they have a hemorrhage, okay, then they die. So that's what was happening. Stroke prediction, I won't get into the details, but this is, you guys are into stroke prediction tools. This was a paper which looked at 8 different stroke prognostic tools in ischemic stroke, called the Astral study. I'd recommend that if you're going to use an ischemic stroke prevention scale, use this one. Okay? Because they've studied them very thoroughly, and here's the area under the curve. And this thing clearly separates itself from everything else. This is the scale. I put this line in here for you to see that this is 1 point for every 5 years. So a 50-year-old gets 10 points. Okay? And a point for every NI stroke. So while you have these other factors, I mean, these numbers have the ability to contribute 8 points. These two have the ability, they're going to contribute 50 points, you know. So this is really age and NIH stroke scale are the major determinants, and then modified by these. And I put in case you wondered what the glucose was in millimoles, I put that in. I think I need to, no, one more. Okay, this is the last thing, I promise. Okay. CT perfusion. So from the Atlantis trial, and we were doing MR perfusion in the Atlantis trial. Stony Brook was the only MR site. What we saw was that if you did a perfusion scan and you had a penumbra, and in the middle of the penumbra you had an area where no contrast went, okay, and then you reperfuse them, they were going to hemorrhage right there. All right, that's the core. What they're saying right now is that's a necrotic center. Okay, so they're using that as a way of estimating the core of the stroke, just like you would use diffusion imaging. Diffusion is better, okay? But they're using this as a core. And what they found, they compared this to the aspect study score and found virtually no correlation at all. Virtually no correlation. So I'm telling you that and in addition, the aspect missed a couple of major, look at this. So there's an aspect score of, I don't know if it's 0 or 10, but it's, you know, one extreme. This is the area of severe reduction of blood flow at the same time. This is the patient 2 days later. Okay? And this is the range of the size of the core as determined by the CT perfusion at each of the different aspect scores. Huge ranges. Okay? The aspect score does not work. It's not useful. And if you rely on it, you're dealing with nonsense.
Can you estimate the core by looking at the density of the ADC?
Density of what?
Of an ADC?
Oh, yeah, definitely. You definitely have. John, can you use the ADC? If they're under 550 on the ADC, is it definitely. I don't know if we have a Photoshop, but we've been using that forever. 550 is the cutoff for the core on ADC. And I think there's just a couple other things, and I think I'll show you some pretty pictures, and there's more good stuff. This is maroon bells in Aspen, Colorado. Can you tell it's Aspen? Predicting malignant edema, treating malignant edema. Oh, this is a great study. I love this one. Giant cell arteritis. Do you guys know this drug, tocilizumab? Who here, forget this, who here would have treated giant cell arteritis with tocilizumab? Yeah, not me either. So, and yeah, look at this study. This is great. This was a nicely done study of either weekly tocilizumab or every other week. These are the interleukin-6 inhibitor with a 26-week prednisone taper versus a 26-week taper or a 52-week taper of prednisone. This is a nice study. And it produced much more, look, 50% sustained remissions, meaning after they stopped the drug, they didn't have to go back on anything, versus, you know, very rarely does that happen with prednisone. Lower complications, and this, I looked up, I never heard of the drug. It's FDA approved, it's commercially available. The cost for a treatment would be $21,000 if you did every other week, $42,000 if you did weekly for a year.
How long do you treat? How long do you treat?
For a year.
For a year.
And my conclusion is that you better search, when you encounter diseases that you don't treat very often, you should do a literature search. Even if you think you know how you want to treat the patient, I would do a literature search, because you never know what happened since the last time you saw one of these. I mean, you're going to see one of these a year or something like that, that you're going to be, you know, each of us, as we split them around, a lot happens in a year. So, and this drug is, like I said, this is just available. And this was the, this is 0 to 100. This is a big difference. So this is a really nice study. This is the Eiffel Tower from beneath. I love that. What else do we got? Clinical pearls and quick hits. We're going to dispense with those. We're going to dispense with rehab. Modern medicine, and this is a hobby horse that I'm on. Everybody's into readmissions, readmissions, readmissions. The answer is you can't do a thing about readmissions. Readmissions occur no matter what. The readmission rate of 12% for all stroke admissions nationwide. It's going to be determined by race, and education determines the readmission rate. If your population is more black, if you have, listen, over 15% African American, then you're going to have higher numbers. If your high school graduation rate is less than 80%, you're going to be in a high group. Okay, and that's that. The readmission rate in subarachnoid hemorrhages, and this fits with what we find. It's always medical. We had, I don't know what, 80 readmissions. 4 of them were for stroke, okay? The other 76 were UTIs, aspiration pneumonias, skin breakdown, falls, fever of unknown origin. It's nearly always infectious. It's always medical and never a recurrence. And this is where I am going to stop. The readmission rate for all diseases, this is New England Journal a week or so ago, the best hospitals in the country, the best are 15%. The worst are 16.3%. That's the range for the entire country, from the best hospital to the worst hospital, is 1.3%. And that, by the way, does not take into account, the demographics. And that's it. It's like we're knocking ourselves out over nothing. We cannot control this. This is not something that we can deal with. Morning at Wisconsin, different colors. Isn't that, I mean, is that amazing? That's just off the pier. Okay, all right, thank you very much. Faculty are asked to stay. Barry Marks and Jane Winsky from the practice plan are joining us and are ready to go. So if the faculty please could stay.
Only the faculty.
Yeah, faculty only, right? Bye, everybody. Thank you.
So for the intracranial hemorrhage, when you said intracranial hemorrhage and translate for opulence, you gave like 8 months as a 8 weeks to restart. What about this switch? The time assuming that it's closed. Let's say warfarin was therapeutic twice you switch. Patient that really has ICU.
Yeah, I guess.
Any reason.